make a start. So this is an update from the National Early Inflammatory Arthritis Audit. I'm James Galloway, and I'm delighted that you've been able to join. The purpose of this talk is to give you a sense of where NEIAA is up to, because we've obviously been paused, to talk a bit about the switching back on of NEIAA and how that can be advantageous to you, and also about data entry for organisational data. We'd normally collect that in the spring, and we obviously didn't this year. There's a couple of updates I want to give you about the platform, and that are designed to try and understand and facilitate remote consultations. And I will also mention briefly the best practice tariff and the annual report. The pandemic is ongoing, isn't it? We're 6 months in now, and I think it's a tough time. There was a great blog I read early in the week from someone who'd been in Sierra Leone when Ebola happened, which comes, nearly sort of 7 years ago, and they were saying how the 6 month time point was a disheartening time point for everyone. It is no longer with the adrenaline of the pandemic starting, the realization that the end is still a long way off, and that the day-to-day work has to be done. And I think it is quite a disheartening. I certainly have found, my mood has been up and down through all of this, but at the moment we're aware that inflammatory arthritis still exists, very much so. We are seeing people who ideally, I think I've come across people we would have seen sooner. Our services are stretched. Our access to clinic capacity has changed up and down the country. Where I work, our face-to-face activity remains dramatically reduced. But there is no diminished level of desire to care for people with rheumatic diseases. It's not that rheumatic diseases are less important because of COVID, and the impact of our diseases is substantial. And as a community, I think we still want to do the very best by the people that come to our services. So the national audit is a tool to do that. But of course, when COVID happened, we suspended everything. We, from the 1st of March, expected no new data collection. Actually, towards the end of February, the data being collected rapidly tailed off. And we did see some data entered because the portal remained open for people to access, just there was no requirement to report, and to be honest, no clinical activity in many places happening. But I'm aware that quite a few units did contribute their follow-up data from the previous calendar year to get that up to date. And thank you for people that did that during the pandemic. One thing that's worth mentioning though about the sort of pause period is, during the period that the pandemic happened, is we did publish the supplementary report. So this was an addendum, if you like, to the year 1 report. You'll be aware that we collect data at 0, 3 and 12 months in the national audit. The 12-month time point, that data point at 12 months is a data point that collects information on whether people are in remission 12 months, whether people have had an annual review, and if they did, what was in that annual review, and whether they converted to biologics. Now, for obvious reasons, we didn't report on that information in the first annual report, because only the people who recruited at the very beginning of the audit back in May 2018 would have had that information available by May 2019. So if you to get the 1 year data, you really have to wait to the end of the second year to get a full year 1 end data point. So to address that, we published a supplementary report which waited a little bit longer and had a data cut in October after the first year. So if you like, an early look at what outcomes we see at a year. And that included also the linked data with NHS Digital. So how many patients are being admitted to hospital, how many people are having joint replacements and mortality rates. So I'd encourage you to look at that. If you've not seen the supplementary report, it's now published by HGRIP, it's online. And I think it's really helpful, because a big bit of what we do in the audit is measure process. And it can sometimes be easy to forget that at the end of the process, there are really important outcomes that are linked to that. Whether people are in remission at a year, whether people need joint replacements, and so forth. So that supplementary report, I think, was really helpful information, helpful context to the audit, and is broken down by trust, and that is available online. But this audit is about sort of how we see our patients, and the process measures are a fundamental bit of what we capture in NEIAA. And I think now more than ever, there is an opportunity for us to use the audit to support us switching services back on where appropriate. Because, I think questions like, are we worried about waiting lists? Have our services been pushed aside to make way for other acute care services? How many of us have lost resources during the pandemic? And in order to argue our cases, say, no, we absolutely have to deliver rheumatology services. They need to be switching back on. We need to be providing face-to-face consultations where appropriate, for example, for new patients. I think if you ask us all honestly, how many of us believe you can really get good quality early inflammatory arthritis disease in remission with complete telephone follow-up, it's challenging. And NEIAA is a really useful tool here because it puts rheumatology on the NHS agenda. It flags our performance to the CCG, it flags it to HQIP, it flags it to the CQC. And that makes it a very powerful lever at our disposal to advocate for our services, to be able to say, when we go to our managers, if we don't do well at this, then this will be flagged up at a CQC report. And having it on that radar, having it as part of the CQC dashboard is powerful. It gives us a justification saying we've got to get these services back up and running. I want to now mention just a few bits about the changes to the website. And if you are logged into the website, you'll see that you can enter into organisational data forms again. So normally we collect the organisational data in May. We have postponed that, but it is now switched on, and you can add in the organisational data from now up until Christmas. People have got there's been some questions about what do you put in the organisational data, and here's the form. This shows you what the organisational data form looks like, and it's an identical form to previous years. The questions have come up is, are we answering this form how we are now, how we were before the pandemic, how we're expected? So the answer is you need to answer this based upon the services, the availability of services that you're providing from when the audit is collecting data, which is basically we've had a go live to being open to collecting data from the 1st of September through to, and this is going to run through till April next year. So so you need to look at what your service is like in that time window. So it's not what happened to you during the COVID pandemic, because we didn't collect any data then. It's what the services look like now. And if you've got questions, if you hover over the question marks down the organisational form, for example, if you're to hover over the question about what does it mean when you say whole time equivalents, and people have asked us a common question is, what about whole time equivalents for academics? How do you count that? So, and the help says that, so for consultants on academic contacts, the whole time equivalent should only account for their NHS clinical time. So it's to get an idea of how many whole time equivalent NHS consultants are working in the department. And you'll see throughout the form that if you hover over the question mark, it may answer a question that you have. The other things we've changed around the platform is some of you may have noticed that the way we do consultations has changed a little bit. So this is my office. I don't quite know why I put a photo of me on the desk, but anyway, it has meant that I'm doing clinics where I'm calling patients and doing consults from my office rather than from the clinic. And this does change things. So when you log into the audit, there's a few things you will notice. So as you log in and you enter your patient demographics, one of the things we've changed is we've added within the diagnostic form, how was the consultation conducted? Face-to-face, telephone, video call, not known. And the purpose of this is not that this is something that HQIP have asked us to report on, but I think this is helpful for local units when you're looking at your own data to be able to, this is a way you can capture how the consultations are taking place. So when you're looking at your early arthritis, new patient, and then the 3-month and 12-month follow-up, how those are handled. I think so this is there to help you. It's one additional question that we've added into that diagnostic form. We have tried to keep any additional information to an absolute minimum. So the rest of the form on the clinician side isn't changed, except one bit is that we do show you some different information which links to collecting a self-reported DAS from a patient. And I'll show you how this works. So when you enter the clinical baseline, when you go into the clinical baseline form, hold on a minute, I may have just missed. No, I didn't. When you go into the clinical baseline form, there is a form that you'll see it comes up that says patient in yellow, in blue at the top, patient PRO baseline not yet started. Now, if you had in the demographic information provided a patient email address, and that patient has then received an email inviting them to take part in the patient-reported outcome measures that are collected through the national audit. And I remind you that we know about 40% of patients who are in the national audit have returned patient-reported outcome data. So this is not for everyone, but of those people that do, when they click through the patient-reported outcome data, that includes a patient-reported self-DAS. So that information is being asked from a patient. And if they have entered the self-reported DAS, the tender and swollen joint count and the global score from the patient-reported DAS will appear in text on the clinical baseline. And correspondingly for the 3-month and 12-month, if they'd filled in those, they would appear on there. And it doesn't populate the tender or swollen joint count that gets entered into the national audit. All it does is shows you the information the patient has supplied. It is then up to you whether you think it is clinically appropriate to include that and add it in, or whether you will discard it, because it's still up to you as the clinician entering the data to populate those boxes. So if you had a face-to-face DAS, you would preferentially put that in, of course. If you don't have a face-to-face DAS, then you need to make a judgment. And and I think there are challenges around doing self-reported DAS. When the patients go onto the self-reported DAS platform, and some of you have seen it on the EPROMS, the BSR EPROMS platform, because it's the same system that's being used, that's just been mirrored across the two sites. There is a link to the NRAS, how to do a self-DAS. There is also, we're doing some work at the moment in the background, looking at how we can also get better training for patients to help them. So some sort of free online training for the patients to do self-DAS. But I think the challenge is that if you have a patient who's got a low disease activity and they've got no tendon or swollen joints, and they tell you that, then that's probably quite a good marker that they probably have got a low swollen joint count. People with high swollen joint counts, high tender joint counts that are self-reported, there may be a less certainty that that is an accurate reflection of the objective measure of inflammation, and particularly if there's concomitant fibromyalgia. It's not that they're wrong, they obviously have counted their joints and that's how many they perceive as tender or swollen, but it may make a difference as to treatment decisions and whether you would escalate or switch treatment. So there's quite a lot of data published on this, and just to give you some headline numbers, if you look at the correlation between a physician and a patient tender joint count, it's about 0.78. So a correlation above 0.7 is a good correlation. For swollen joints, the correlation is not quite as good, it's close to 0.6, but it's actually on the right, you can see the agreements of patient and clinician agreements, and actually the agreement falls off at the higher levels. Interestingly, if you were to compare tender and swollen joint counts between different physicians or different clinicians, the differences are not that marked. The differences are similar when you compare between a patient and a healthcare professional. So that's food for thought. But anyway, the system has added that. It's there to be used if you choose to use it. It's there to be ignored if you choose to ignore it. It may be helpful for some patients, and we hope it may give you a way to collect a self-reported DAS in a remote consultation. So here you go. This is, I think, just a short video, I think, which is now just going to show you the clicking on the patient to the self-reported DAS. So when you click on, so this person, you can see they have got partially completed MSKHQ. And if I was to click on the patient baseline, this here showing you what the self-reported DAS looks like. So as the patient would see this, you can see it as well. You can scroll down, you can log in and see, first of all, the advice, so how to do it from the NRAS. There's some information on the mannequins about how to use them. So there's some instructions. You've got a mannequin for tender joint counts and swollen joint counts, and as the clinician, you can log in and see which joints they specifically have ticked on, so you can see where the symptoms are. And if you carry on down at the bottom, it's off the screen, but there's also a patient global, which is a ruler on a visual analog scale. And so that's what the patient sees, and what you as the clinician sees at the other end of it is just the numbers that will auto populate in the clinical baseline 3-month and 12-month forms as appropriate. So final couple of slides. The first thing is about best practice tariff, because obviously the national audit reports on the best practice tariff. The best practice tariff went live in April last year. We reported for 3 cycles, 3 quarters, but then the best practice switched off in March. So all best practice have been paused, and until they switch back on, we're not currently reporting on any best practice data. When they do switch back on, so one thing is when they switch on, and this is relevant from rheumatology services perspective, is we cannot judge best practice tariff performance on a patient until 3 months has elapsed since they were seen in the clinic, because you have to meet the standards within the national audit, of which that includes recording a patient reported outcome measure and a DAS within the first 3 months, and also obviously they need to have started on treatment. So we can't judge performance on the BPT for several months. So if the BPT was to switch on today, we would be looking at performance over the last 3 months. So you have to start collecting data in advance of when the BPT reports. So there is an advantage, although the national audit is not mandated back on yet, none of the HGRIP audits are being mandated at present, and we're all aware of the current situation and what may change. But if you want to be ready for best practice tariff, then you need to start building the data back in the audit. And I think there's the audit system is switched on, and we're ready to receive data. And as data start to come in, we will report back to you. And obviously you can download your own data. The other big piece of work at the moment is we have done the annual report from 2019 to 2020. And we did this report with the data cut was in May, of course. And so there was no data in this report that actually was after the 1st of March. It's challenging how this is going to be interpretable, because so much has changed since this report was done. Although for any unit that looks at their performance, and in this, I think you can look individually and say, well, where do we learn? Where are our weaknesses? Where are our strengths? And how do we compare to our peers? You can do that, but it is going to be in the context that what has also changed in your department since COVID happened, because we know there's so many things that have shifted, so many changes. But I hope it will be useful. The report has been written. It has been through the first sort of round of peer review at HQIP. They review it all, they send it back with comments, and we have sent it back again. So I'm anticipating that I hope we'll see this report in the public domain in the near future. The report, as it currently stands, I'm really cautious of what I say here, because the goalposts do sometimes change on this. But at the moment, the report does not list outliers. So we are reporting everyone's performance, but because of COVID, we're not identifying outliers. However, the latest communication that's in the public domain from HQIP is that outlier notification is going to switch back on, and they are going to ask us to share data on knowledge of outliers wherever possible. So at the moment, what we've done, and some of you may be aware, we have contacted units that were an outlier at the 3 standard deviation level. We haven't been notifying the CQC or reporting back to HQIP as yet, but I think it is very likely that this is something we'll be looking at, and the guidance may change on this, because otherwise, if we don't report on outliers, then it essentially means we've done an enormous amount of work and 9 months of data collection that we don't use. The challenge will be at the trust level, working with trust managers and with your, with the people in individual units, to understand how you interpret data that is pre-COVID. Although I know that in my unit we have challenges, and actually a lot of the things that have happened during COVID, I think actually will help us deal with some of the challenges that we were facing pre-lockdown. So in summary, I hope that I think NEIAA is a positive force. I think if you look at the latest annual report, and it's embargoed, but one striking thing is the performance against quality standards, but also the change in how many people get into remission has been really striking, and I think it is change for the good. I hope that you will use it to your advantage. There is some minor tweaks that have happened this year. Highlights being organisational data entry is now open. You can enter the data for your unit if you've not already done so, and that is to reflect your unit structure at the current time, not during the pandemic. We've made a couple of minor changes to the platforms, which I hope will be helpful locally. For example, capturing whether consultations are by telephone or video or in person. And we've also added the self-reported DAS tool within the system. To remind you, best practice tariff is currently switched on, and watch this space for the annual report. So that was all I was going to say. Thank you very much, everyone, for listening. I've tried to keep this short and sweet as an update, but I'm not going to leave, so I'm very happy to ask any questions if I can. By all means, use the chat, but I will stop the recording at this point.